Thanks again to the cast board. Thanks for everybody for coming to join us. I know that this definitely feels different, but to be able to still have collaboration with all of you guys is really truly an honor. I hope everybody is well and staying safe. Um, I do a fair bit of deformity in my practice. About 30%, 40% of my practice is deformity, but this is not about deformity patients. This is really from the perspective of the a degenerative spine, and how can we look at it in order to prevent iatrogenic problems, or at least minimize the possibility of it. I do have some disclosures, none of which are relevant to this talk. Um, Here's just the random sampling of some sagittal views of some of the patients who've been in my practice in the last 3 months, and you can see that as you move from left to right, certainly these are all different types of problems, and they were treated in different ways. But you can see that if you don't pay attention at one level, um, that's really where you can get into trouble at others. And so in this first patient who has isthmic spondy, which, at baseline is, depending on the slip, is a deformity. This patient has, I would say, mid-range pelvic incidence. I don't think he's at very high risk, but for me, and I think for most people, this is definitely an ALIF. Primarily to get that segmental correction and really try to get rebalancing and matching of lumbar lordosis. It looks like the second patient, the previous spine surgeon did try to do that, had paid some attention. But if you look, the pelvic incidence is probably in the low to mid range on this patient, and they're still collapsing and spondylolisthesing above and really losing their lumbar lordosis. And so, the revision strategy here, which I'll circle back to I think all of these cases, even though this patient may not be at risk for mismatch um, based on their anatomy, is now may need to be treated differently. And I think that these last two cases just highlight how really, if you're really focusing on one level at a time without a view of the global picture, you can really do a disservice to some of these patients. I mean, you see this very high pelvic incidence patient in the third pane, taken for an L5 fusion, subsequently break down for an L4 fusion. And you can see almost, the top of the L4 disc space, which is the top instrumented level, is almost at 45 degrees, rather than horizontal to the floor. Additionally, the guy in the last pane was a very close patient of mine. We did a lot of work for him, but he came into the office like this. This is 5-6 surgeries of work, and some with different surgeons. And again, if you don't pay attention at each step when you're addressing the main presenting symptom, I think it can run away and get into a major problem. So the key points to ask, as somebody who may not do a lot of deformity, I think really is, did I get all the appropriate imaging that I need? To carefully consider what the main cause of pain and disability for that patient is. And then to really critically think about the alignment needs of the patient. And to echo Tom, I think, or to echo John, I think every week there's a new measurement that's supposedly the most correlated with the best outcome, and sometimes it seems a little bit overwhelming. But I think just focusing on a few numbers can help your thought process. And thankfully, I think with the attention paid to it over the last 10 to 15 years, I think a lot of us hear this on the podium, over and over again, sagittal balance. And I think that as a community, we've done a much better job with it, maybe too good of a job, and created some PJK along the way. And so the last question I asked myself is incremental improvement possible while addressing the other three? So this is a patient of mine who, going back to Chol's kind of thought process on how to do a Tlift, there's many ways to do a Tlift. This person is not particularly out of balance when you look at their spinal pelvic alignment. PILL is actually pretty reasonable. His PI is not, I would say, in the mid range. but he has, focal kyphosis through the L4-5 disc space. And actually, there's some unrecognized compensatory mechanisms. You can see that he's fish mouthing at the 3 disc spaces above. He's a little retrolesthese. So even though on a standing film, this patient is well aligned, and you say, hey, I don't know if I really need to do anything, his pelvic tilt is not up, this is somebody who I think has a little more deformity than the numbers show. And so nobody would say you need to do deformity correction operation on this patient. But if you are doing a Tlift, I think trying to get an anterior cage, doing some facet releases, really trying to maximize lordosis, or at least maintain it, would be beneficial. I think this was a little earlier in my practice. I would have treated this differently now. I would have perhaps done like a little bit of a pseudo ALL release with an X-lift technique, and then cut the facets and tried to get a little more. You can see as in his postoperative course, he is now kind of compensating hyperextension more. So what is appropriate imaging? Especially with some insurance carriers, I get patients all the time who come in with an X-ray like this, and then I can't get another X-ray. They've already had lumbar X-rays, but I really do think that it is important. Even if you only have lumbar X-rays in your practice and you don't have the ability to get 36-inch scoliosis X-rays, to really make a point to include the femoral heads. And I think with that alone, I think you can usually avoid the majority of these types of mistakes. Of course, if you have 3-foot films or EOS, which we have, scoliosis films, but not EOS, been trying to push the institution for that for some time. But that's something that you might go to and send out if you don't have in your practice, especially if the initial films demonstrate mismatch, just so that you have all the information with which to counsel the patient. You can see that with lumbar films, with femoral heads, you can at least get a sense of the pelvic tilt as well as the PI-L mismatch, even though you may not get an overall sense of their SVA without scoliosis radiographs. Now, we know the deformity correction goals. We've heard this a lot. There's a lot of emerging angles, the lumbar pelvic angle, T1 pelvic angle. But these are for deformity patients, and these numbers are for adult spinal deformity patients, as opposed to degenerative patients who are coming in and may have some functional deformity to avoid neurologic compression. And I think that if we focus too much on these parameters, I think you risk really taking someone with a focal problem who really has a well-compensated deformity and over-operating on them. So this takes me to what is the primary symptom. And if you remember this case from before, this patient came in. You can see he has severe adjacent segment disease at L5S1. I mean, it's essentially a myelographic block at L5S1, vacuum disc space. So he had horrible claudication and radicular symptoms, which matched this level, but that was about 50% of his complaint. The other 50% was, I literally can't stand up. I do my job as a bus driver, but I can't stand up. So clearly both were affecting him. Somebody attempted prior to his presentation an MISD compression at the L5S1 level. I think they weren't able to quite do it, or had difficulty with the dural tear. Kind of sealed them back up and said, well, I don't know how much more that we can do for you. So this patient, clearly, if you only dress his neurologic compression, is not going to give him substantial relief. And this is a deformity patient. This is somebody in which a 3-column osteotomy is appropriate and restoration of their spinal pelvic alignment. However, if maybe he had more mild to moderate deformity and is coming in truly only with the functional anterior truncal inclination to relieve his neurologic compression, that's somebody that you may choose to even accept a little bit of deformity and just do decompression. This was a really nice study by Aaron Buckland, trying to look radiographically at what compensation for actual lumbar stenosis looks like versus spinal deformity. And what they found is in patients who had mild or moderate malalignment, so just slightly elevated pelvic tilt, not very out of alignment, the stenosis patients, instead of recruiting pelvic tilt for compensation, actually tended to tolerate some more SVA, so anterior truncal inclination, and tended to shift their pelvis posterior, so more compensation from the lower limbs, as opposed to deformity patients who tended to recruit pelvic tilt earlier, which makes sense because trying to keep the lumbar spine in relative hypolordosis, again, to open up the neural elements. In severe malalignment, both groups tended to look more similar. And the takeaway point for me there is patients who have severe deformity will tolerate their claudication because deformity, when significant, is so disabling, and they want to maintain an upright posture. And so really, I think the severity of somebody's malalignment ends up being, a determining factor along with their main presenting symptom as to what you may prescribe for them. When I look at an x-ray, I'm always looking at the alignment needs. I mean, I don't use SurgMap or anything like that. I just measure off, the angles on synapse, but get a good view of the femoral heads. And this is somebody I would say who is kind of in the medium to high PI. So whatever you do, whatever needs to be done, if they're going to be instrumented, this is somebody who you have to think carefully about how you're going to maximize the lordosis at the segments that you are treating. Also, the emerging concept of age-adjusted norms, what is normal for a 51-year-old patient, which is what the initial parameters for deformity were developed on. Average age of those patients in that landmark study was 51. And now, as we know, a 75-year-old is going to behave differently. And so you may be accepting more mismatch. And this is then kind of the last point. What can I do? What strategy can I use to get incremental improvement? And you've heard, a great talk by Chol. You can do it with a Tlift if you're a talented surgeon. Just don't be a one technique surgeon, because I think one technique will not solve all problems. You may be a posterior based surgeon, but realize that there is a need for anterior surgery when somebody is truly mismatched and you need to maximize lordosis or correct a deformity at that segment. This brings me back to that one patient. Again, I did not feel like he was, had a significant deformity, but you could see that the mismatch between his relatively mid to low PI and lumbar lordosis was significant. This I utilized an X-Lift technique with. I don't do a full ALL release in this case, but just a really aggressive discectomy and put the cage anterior, combine it with fascectomies, and you can see, at this was, I think, up to about 12-degree correction at this level. So what about if we leave people malaligned? Are there worse outcomes? And I think that the literature really is a little bit contradictory. There's definitely some controversy. In laminectomy patients, this series showed that there was no difference in back pain when patients were malaligned, although if you had better alignment, they had improved walking ability and social function. In an instrumented fusion population, the second series showed worse back pain when the L1 plumb line was greater than 3.5 centimeters, so some amount of regional imbalance. And then with increased pelvic tilt after instrumented fusion, the series demonstrated some increased pain. So I think certainly a tendency, perhaps, in instrumented cases towards increased pain. But actually, most of the literature certainly is based on really truly deformity patients, and degenerative literature is actually a bit lacking. What about leaving somebody malaligned and creating adjacent segment disease? Certainly PI-LL mismatch, insufficient lordosis, and abnormal SVA have been implicated both in short segment and long segment as a risk factor for adjacent segment disease. And so that, of course, really supports the idea of fractionally correcting as much of that you can of the segments that you're creating. In this patient treated with a stepwise posterior lateral fusion with really no attention to lordosis, you can see that perhaps a very big operation may have been avoided for them down the line. So in summary, just get appropriate radiographs, get the femoral heads, go through the practice of measuring. I look at, really pelvic tilt and the PIL mismatch on the DGEM patient, and then we'll get a scoliosis film if I feel like there is any imbalance. And really, we are looking at, in the degenerative realm, the smallest surgery to address what their primary problem is, but look for ways to gain incremental improvement of the alignment. And just for patients who do have more severe deformity on these measurements, they're probably less likely to achieve meaningful improvement with a focal operation. And these people should be certainly carefully counseled, but potentially offered, more invasive procedures.